Alrighty, what's going on, guys? It's Ethan from Disease Crash Course again. Now, first things first, I want to give you guys a heads up that I changed my name from NP Crash Course to Disease Crash Course. I decided that I wanted to make it a little bit more broad because PA students as well as medical students, they can utilize this information as well, not just NP students. So I just don't want to narrow it down to just NP students and, potentially if PA students or medical students, see this video or the thumbnail, but they decide not to click on it because it's NP crash course, if you get what I'm saying. So I decided to just rename it Disease Crash Course so that more people can take a look at this info. Now, hopefully you guys like the first 3 videos I uploaded. If you have any issues with it, if you feel like I should improve on anything, or if you want to see my face, anything of the sort, just give me a holler. Just comment down below, and I'll take all of your notes into consideration. And so just make sure to like, comment, subscribe, and we're going to get into it right now. So we're going to be talking about acute kidney injury. Let's take a look at the pathophysiology. So, acute kidney injury is a sudden decline in kidney function resulting in the accumulation of nitrogenous waste and electrolyte imbalances and fluid dysregulation. Now, this occurs through 3 primary mechanisms. You have pre-renal, which is hypoperfusion without intrinsic kidney damage, such as dehydration and heart failure. Intrinsic, which is direct injury to renal parenchyma, such as acute tubular necrosis and glomerulonephritis, and post-renal, which is obstruction of urine outflow, such as BPH and kidney stones. Now, the KDIGO criteria defines AKI as one of the following. Serum creatinine increase. It is an increase by equal or more than 0.3 milligrams per deciliters within 48 hours, or an increase to the serum creatinine by equal or more than 1.5 times the baseline within 7 days, or the urine output being less than 0.5 milliliters per kilograms per hour for 6 hours. Now let's take a look at the signs and symptoms. So a patient with AKI might have these symptoms such as oliguria or anuria, going to be less than 400 milliliters per day or less than 100 milliliters per day of urine output respectively. Nausea, vomiting, fatigue, confusion, peripheral edema, shortness of breath, which is fluid overload, flank pain, possible in the post-renal obstruction, and uremic symptoms in severe cases such as pericarditis and asterixis. Now, let's take a look at the focus physical exam. So with the focus physical exam, you're going to take a look at volume. So assess the dry mucosa, check hypotension, assess your JVD, edema, and crackles upon auscultation. Additionally, you're going to have CVA tenderness, and that could suggest an infection or obstruction, as well as bladder distension, post-renal cause, and neuro, which is asterixis, confusion, and uremia. Now, when it comes to the CVA tenderness, just remember when you do CVA, you just got to find the 12th rib, and then place one hand over the CVA area, and then use the ulnar edge of your other hand, and then percuss to the back hand that's already placed on the CVA. And then if there is tenderness, then you're going to know that's infection and obstruction. So let's take a look at the diagnostics. Let's take a look at the labs specifically first. So of course there's going to be an increase in the creatinine level more than 1.3 milligrams per deciliter. BUN creatinine ratio is going to be more than 20 to 1, which is going to be pre-renal. And then potassium, there's going to be an increase in potassium more than 5 milliequivalents per liter. Phosphorus more than 4.5, and then calcium less than 8.6. With the UA, it's going to show CAS hematuria, proteinuria, and specific gravity. And then you could also take a look at the fractional excretion of the sodium. Going to be less than 1% pre-renal, more than 2% intrinsic. And let's take a look at the imaging. So again, you're going to do a renal ultrasound to evaluate for hydronephrosis. Going to be a possible post-renal AKI, and then a bladder scan, assess for retention. And then an ECG as well to assess for hyperkalemia effects. So some differential diagnoses. You're going to have chronic kidney disease, volume depletion, GI loss, hemorrhage, post-renal, BPH, stones or strictures, glomerulonephritis, interstitial nephritis, and even heart failure with low renal perfusion. These can all be differential diagnoses when it comes to AKI. To point this out, you have urgent care considerations. So when you're going to be in the urgent care, you're going to do point of care creatinine, so UA dipstick, and then you're also going to provide IV normosaline 1 bolus if hypovolemic and no CHF history. Remember that one. Now, furosemide 40 milligrams PO or IV if signs of fluid overload and good urine output, ondansetron for nausea and vomiting, and then immediate referral to ED if creatinine rises more than 1.5 times the baseline, uremic signs, hyperkalemia, or low output. If there's a sign of hyperkalemia, urgent care cannot handle that whatsoever. Urgent care is not ACLS. It is only ER. Patient education and referral. So maintain hydration, drink extra fluids during illness or exercise, avoid NSAIDs and limit contrast imaging unless necessary, monitor urine output and report any decrease or changes in color, take all medications as prescribed and follow up on labs, and follow up with nephrology if kidney function remains impaired. You would also refer if the potassium is more than 6, and there's also signs of acidosis, uremia, persistent elevation. So let's take a look at the ICD-10 and the EM coding tips. So ICD-10 is going to be N17.5 for acute kidney failure unspecified. So you might think, oh, it's acute kidney failure. Is that the same as AKI? Yeah, you're going to be using acute kidney failure for AKI. That's going to be the ICD-10 you will use when it comes to documentation. Now for EM coding, you would use 99214 for AKI management with labs and medication adjustments, and then 99215 for acute kidney injury with electrolyte abnormalities and care coordination. Now for referral and admission criteria, you would refer if there's a rising creatinine despite fluid management, electrolyte abnormalities, so potassium being more than 6, severe acidosis, uremic symptoms such as pericarditis and confusion, suspected intrinsic disease that might need a biopsy, and dialysis indications. So AEIOU, acidosis, electrolytes, intoxications, overload, uremia. Just remember that acronym. So for dialysis indications. I decided to put in a documentation tip. So if you guys need help with how to document in your notes, I provided like an example. So let's take a look at this. So patient with recent GI illness presents with fatigue and oliguria, vitals stable, labs going to be creatinine 2.1 milligrams per deciliter, BU1 48, potassium 5.9, urinalysis pending, started on IV normosaline bolus, monitored INO, planned outpatient labs, urgent nephrology referral, follow up in 24 to 48 hours. This is random. This isn't from a patient, but it's just an example on how you can document. If you could like this tip or this slide, let me know and I'll continue doing this one. I decided to put it in just to see if you guys would like it or not. And clinical pearls. So pre-renal is the most common and usually reversible. Always review patients' medications. Watch out for the NSAIDs, the ACE inhibitors, and the diuretics. Avoid contrast unless essential. Serum creatinine may lag 24 to 48 hours behind injury. That's a big one. And always assess for urinary obstruction in all patients with AKI. And thank you for watching. So make sure to follow, well, now Disease Crash Course for more nurse practitioner content. Just make sure to like, comment, subscribe if you like this video, and let me know what I need to do to change or to get better when it comes to any future diseases we're going to cover. So we have a whole lot more in store for you guys. Or I have a lot more in store for you guys. But yeah, thank you for watching. Hope you guys have a good rest of your day.